All right, let's get started. So please join me in welcoming Dr. Barbara Jones, who is our Grand Round speaker today. Just a little bit about her. After medical school at University of Washington, Dr. Jones trained at University of Utah as a resident and fellow. During her training, she obtained her Master's of Science in Clinical Investigation. She ultimately stayed on as faculty and over the years has helped broaden our understanding of pneumonia care in particular. She has been the recipient of multiple awards and grants, including the VA Investigator Initiated Research Award most recently. She currently serves as the co-chair of the American Thoracic Society and IDSA Clinical Practice Guideline Update for community-acquired pneumonia. A little bit about her research. Her research focuses on understanding and improving decision-making in pneumonia. Her work is founded upon an informatics lens, utilizing population analytics, qualitative inquiry of cognitive behavior, and clinical decision support. She's been particularly interested in examining mechanisms of variation in diagnosis and treatment, and has helped develop paths to improve pneumonia patient care across the VA and University of Utah health system. As a clinician and researcher, I'd be remiss if I didn't mention her passion about improving the care of patients across diverse settings and care environments. Dr. Jones has already contributed greatly in bringing evidence-based practice and solutions to ensure excellent patient care. So I'm really, really delighted that you've joined us today. And the title of today's talk is When the Rubber Hits the Road, Individualization of Clinical Practice Guidelines in Pneumonia. Thank you.
Thank you. Appreciate that. That was a very nice introduction. Really great to meet all you guys today and see you here. And I'm really excited to talk to you guys about pneumonia. It's one of my favorite things. I'm just going to make sure I can advance. Here we go. Okay, here's your accreditation number. Need to pause this for a little bit or move on? Okay. I just have to also disclose, I have no official disclosures, but I like to tell people about my funding because it does influence my thinking a little bit. But all the views expressed are mine, not representative of my funding sources, which are the VA, CDC, and the Moore Foundation. And I also am a chair of a current, in development guideline update, and none of those views that I talk about today are representative of that group. But the other disclosure is that I'm a real sucker for analogies, so I have to warn you, I snuck in at about midnight last night, like a third analogy, but I really have two official analogies in this talk. Okay. All right, so a little bit more about me. So I'm actually not really your traditional kind of medical path person. I was minding my own business in college as a philosophy major. And then I took a history class on US healthcare. And I saw a bunch of stuff that was presented by these guys from the Dartmouth Institute, because I was at Dartmouth College. And I don't know if you'll notice this map of Maine. It was one of the early Wenberg studies that demonstrated this huge variation in actually admission for, kind of ambulatory sensitive conditions like pneumonia and heart failure. Basically across, a river from county to county, you could have like a twofold variation. And they were looking at this with, things like hysterectomies and C-sections and stuff. And I thought that was just fascinating. And I wasn't really from a background of, medical people. My mom was a teacher, my dad was an engineer, and I was just kind of imagined that healthcare was like, really rational, application of science to, human physiology. And so when I saw that variation, it actually became really interesting to me. And so I kind of entered, the medical field from the curiosity of variation, but also there was something wrong with that because I was also learning about social justice at the time. And there was something wrong about, all of that variation in healthcare. So, here we go. In terms of our objectives, we're going to talk about some key challenges to individualizing pneumonia care. I'm also going to talk about why current evidence-based guidelines are not really well matched to clinical care currently. And then we're going to talk about ways to individualize under uncertainty and the role of the clinicians and the role of system leaders. So one question I have for you guys here is, how many of you are clinicians, like practicing pulmonary critical care? Okay, just about everybody. Okay, how many of you guys are have like an operational role, like maybe an ICU director, or you know, kind of like build sort of QI projects or pathways or things like that? Okay, cool. So think about those two perspectives. And how many of you guys do research? I'm just curious. Okay, all right. I have a research talk tomorrow, so I'll try to not geek out about research too much today. All right, so here's my first analogy. Okay, how many of you guys play like a medical or play a medical instrument? How many of you guys play a musical instrument? Like, okay, cool. Do you play like classical? Okay, anybody play jazz? Okay, like nobody plays jazz. Okay, so I was sort of classically trained in the piano, and recently I've been trying to learn how to play some jazz stuff, and I found it to be incredibly hard. It's sort of like this totally different mindset. And so I was reading about you know, the different kind of theories in music, and they talk about classical music as something called composer driven. And so what that means is when you play a Mozart piece, the notes really never change, right? You know, it's always the same sonata. But there's a lot of expression, but there's this planned and descriptive kind of composer-driven format, right? Meanwhile, with jazz music, you know, every time Miles Davis played a piece, it sounded really different. The notes actually changed quite a bit, kind of based on the other, you know, players and sort of the moment. And so they call that performer-driven or emergent adaptive. And so both of those types of music require mastery and expression, but they're just a little bit different. And so I'm going to argue today that medicine has kind of these two types of activity as well. And here's kind of a couple examples. So oncology, right now we've got this really amazing stuff happening with precision medicine oncology, right? Kind of the leader in precision medicine here. We're, you know, this is the X-ray of a lung mass, right? And about, you know, 30 years ago, you might have gotten a biopsy and found that it was adenocarcinoma, right? But nowadays, there's a lot more heterogeneity that's appreciated, and we can be a lot more precise because we don't just characterize the type of cell. We know a lot more about that cell, and we now have like PD-L1, you know, inhibitors and really exciting stuff that we can target. But I would still call that kind of a planned and sort of prescriber composer driven activity. Excuse me. Oops, sorry. A little too much animation. Meanwhile, infectious disease, that's also changing. But here's an X-ray from, you know, somebody with pneumonia. And we used to just say, oh, it's pneumonia, you know, give them a bunch of antibiotics and, you know, kind of like, hopefully they get better. But now we actually have some more rapid diagnostics coming around the corner, and it kind of is allowing us to be a little more precise. That said, a lot of times there's still a lot of unknown, right? So it's still a little bit like playing jazz. Okay. All right, so that was my first analogy. The second analogy is something that I heard from David Atkins, who is the previous VA Director of Health Services Research. And I was at a conference for career development awardees about 5 years ago, and he said, you know, evidence is like getting to Everest Base Camp. And I think what he meant by this was that it's a lot of work to generate evidence, right? But the actual like sharp end is actually what happens above base camp, right? To get to the summit, that's actually implementation. And he was really trying to call for a big push in implementation research. And so a past life, I was actually before fellowship, I was a doctor at base camp for a little while. So this is a picture that I took. And have any of you guys ever been to Everest Base Camp? Okay, so I'm going to extend this analogy a little bit farther just to push to see how much it breaks, you know. But if you've ever been to Everest Base Camp, I will tell you, it's kind of a disgusting place. So there's about like 250, 300 people that are all kind of crammed into this place that they pitch their tents in the beginning of the season. And the thing about base camp is you have to stay there for about 6 weeks before you can, you know, acclimatize your body and wait for a weather window to summit. And so everybody's just hanging around. They don't have much to do. It's predominantly men. And also the tents, you know, things start to melt. And so it's all on a glacier. So if you can look carefully at this, all of these tents back here, this is my friend Luann who staffed the base camp all season, and I just kind of covered her for a few times during the season. And see these tents back here, they're all actually like pitched at these different angles because the snow and glacier has melted. But nobody really wants to pitch their tent again because it takes a lot of work. So by the end of the season, you're just kind of like laying on your tent in the middle of the night, like pitched on these weird things. And so I'm going to take this analogy farther to say that Everest Base Camp is actually very shifting and shaky and kind of like a period of sort of ennui where you haven't really done anything, but it's actually kind of fuzzy and shaky. So, all right. There we go. Okay, so problem number one, kind of alluding to that in pneumonia, is that our evidence base is actually pretty shaky and uncertain. So before COVID-19 even, we have been kind of slowly shifting our paradigms in lung infection. We had originally a simple model of lung infection where, I used to think that the lungs were sterile below the vocal cords, right? You can see that in medical textbooks still, they'll say that. And now because of, microbiologic research and actually a lot of research that's been happening at Yale with the host response is we now know that we are not actually sterile. We're kind of teeming with microbes, right? And these organisms are really kind of commensal organisms that are interacting in really complex and poorly understood ways with our host immune system. So we're no longer with this simple model, we're now kind of in a complex adaptive systems model. Where you have a very active host and you're kind of dealing with lots of commensal organisms. And so the focus has become kind of, there was a pathogen focus before, and now there's a lot more of a host focus and the idea that, we're not a sterile compartment anymore. But this evidence is, growing, but it's still kind of challenged by a big problem, which is heterogeneity and really poor generalizability. So we have diagnostic uncertainty, variation in the immune response, and kind of underrepresentation of sick patients in our clinical trials. And so as a result of that, when you look at practice guidelines, so in 2019, they had a really comprehensive update. Most of what we accept as standard of care in those guidelines is actually based on low quality evidence. Of the 22 recommendations, I think only 3 of them are high quality evidence. But despite that, every time you implement these, and I've been kind of in the business of guideline implementation since I was a resident, and every time you implement the CAP guidelines as a bundle, you improve outcomes, including mortality. So there's something magical about implementation of complex interventions that are based on guidelines. And I've been calling this in my mind kind of implementation under uncertainty. So another kind of problem to highlight, we talked a little bit about, is the heterogeneity. So the thing about heterogeneity is we're a lot of people here working on this and elsewhere across the country is trying to really phenotype people in infectious disease better. But currently, in current practice, we're not very precise, right? We have these pretty blunt phenotypes. So the way people think about, pneumonia classically in clinic is you've got a pathogen, you try to kind of take the pathogen, and 60% of the time you actually don't find a pathogen, so that's a little unsatisfying. A lot of percent of the time it's actually can be viral, and then there's bacteria, which we're assuming is responsible for a lot of infection. But then you've also got the host response, and that's also kind of a blunt phenotyping at this point too. We've got sepsis, that's a big kind of clinical manifestation kind of signs, severe pneumonia, ARDS. And this hopefully in our lifetime will improve quite a bit. And then the other problem is diagnostic uncertainty. Is that problem 4 or problem 3? So this is a study that I did and recently came out in the Annals of Internal Medicine, where we looked at hospital admissions for pneumonia from emergency department. And across the entire emergency department to discharge, just kind of looking at the trajectory of the diagnosis. We use natural language processing to identify diagnostic concepts of pneumonia in clinical notes, including the ER note, the chest image report, and then the discharge summary. And we wanted to see how frequently those diagnoses changed across the hospitalization. And what we found is actually a little bit over half of the time, a patient with a diagnosis of pneumonia at some time in their hospitalization had a switch. And it was kind of equal, about 30% of the patients that started with the diagnosis of pneumonia changed to something else. And about 30% of the patients who started without a diagnosis of pneumonia would actually have a diagnosis at the end of hospitalization. And so the fact that this has so much switching, this kind of has implications on our evidence base. One of the big things that I like to point out is a lot of our evidence-based medicine in pneumonia is based on observational studies that are retrospective and really rely on the discharge diagnosis to make that kind of build that cohort, right? But if you actually have about 30% of the patients who initially are started with a kind of treatment pathway of pneumonia, but they actually don't get into those cohorts, you're really underrepresenting your patients that actually have are being applied, the evidence base is being applied to. So this is really important in terms of kind of thinking about the quality of evidence coming out of observational studies that hinge on discharge diagnoses. And then for a clinician, it's just really important to remember that we actually often might start a patient down an initial pathway, but we should always kind of be thinking that there's other pathways you're probably trying to apply to those same patients, right? And we kind of tend to get social pressure to force patients into kind of these boxes that are neat, but patients often have a lot of diagnostic uncertainty. Another thing that we noticed is a lot of treatment ambiguity. So about 10% of these patients were not only diagnosis was kind of shaky, but they were given both antibiotics, steroids, and diuretics in the first 24 hours. So the trifecta, right, of what we talked about. And so here's an additional problem. I don't know what number problem I am at this point. The other problem, one thing that we found in some of our qualitative research that we did, we interviewed a lot of emergency department physicians across the VA system, trying to kind of understand the cognitive process of diagnosis and management of pneumonia in the ER. And one big thing is that guidelines really don't match the workflow for clinical decision-making, actually. So oftentimes, a patient, and I was kind of looking at how do you design decision support, to implement guidelines for pneumonia care in the ER. And you often have a patient come in and they're initially actually seen not by a physician, but a triage nurse. And then the physician might actually review the electronic health record, then see the patient, and then kind of come up with a gestalt, right? And a lot of the decision-making is made here before there's even a diagnosis. So you have a lot of disposition and treatment decisions made way before the diagnosis is made. And that's a problem because the majority of our evidence-based medicine is based on conditions, right? So there's a mantra, right, that we learn in medical school: you diagnose before you treat, right? But this doesn't actually work in infectious disease when you have, kind of timely treatment oftentimes trumps, accurate diagnosis. So can pneumonia ever actually be precise? So I think the reason, we kind of are challenged, I really want to be like oncology, but there's a few challenges. Oncology is kind of more of the Mozart, right? There's, you almost never treat somebody with chemotherapy, without getting a diagnosis first. You have this composer-driven and planned kind of care. And precision here means, there's coordination, there's tight adherence to treatment plans. You really want to follow those guidelines, very clearly. In infectious disease, it's a little more like jazz. So often there's treatment before diagnosis and, there's action under a lot of uncertainty. And that is that kind of performer-driven and emergent type of practice. And precision here means not, tight adherence to a guideline, but actually anticipation, attention, and flexibility and adaptation. And I kind of like this quote from Miles Davis. I'll play it first and tell you what it's called later, because it sometimes makes me think of the conversation that I have with ER doctors when they admit patients to the ICU with me. And so I'm just going to have a little note. I have been having this great, interesting experience with clinical practice guidelines. And I would say that that experience has been really interesting to see how the sausage is really made when you're developing guidelines. So the way it used to happen is you would kind of show up to a conference and you'd be sort of a socially appointed clinical expert of a disease process. And then you'd sit around with the other socially appointed clinical experts and talk about, how you would, do practice. And then you'd write that down and that would be your guideline. Be like, what do you do, Bob? Well, yeah, I do that too. Let's say that that's what doctors should do. And the Institute of Medicine, kind of around the 1980s, noticed that this was kind of a problem. It was generating guidelines that tended to be pretty biased, might not actually represent the whole field, and sometimes overrepresented kind of like pharmaceutical companies that might be funding those experts. And so they decided to really try to revise the process of guideline development. And I really appreciate this now that I've been part of it. Their purpose, I'd like to think about this as I'm, thinking about guideline development, is to translate the research findings that we have into recommendations that are relevant to individual patients, but not for implementing this kind of one-size-fits-all approach to patient care. And this is becoming increasingly challenging to clinicians because we have this huge evidence base. There's more and more and more papers. It's really the signal to noise ratio for clinicians is becoming really, really hard. And so we're now kind of not asking clinicians so much to understand the evidence, but to know the guidelines, right? But they still, I would have to say, need to know something about whether the guidelines fit for their patients. And that's something that's a little bit tricky. Here's a few things I love about the grade methodology. You have to be explicit about your scope. You have to have stakeholder involvement, including patients. So ATS and IDSA now really require that guidelines have patient inclusion representation. You have to have rigor of development, including a third-party methodology team that conducts the evidence synthesis. So I thought that was really cool. And then applicability. And then another really important thing is editorial independence. So there are people that vet every committee member for conflicts of interest. So when you see a guideline, so the word guideline rather than guidance, that's something that's actually very meaningful. It means that this process has been followed. Okay, so how does it work in actual clinical practice? Now I would say that does this kind of map to like your classic evidence-based medicine, like kind of practice? You have this kind of framework where you go from evidence, kind of integrate that with your expert experience. You've got some guidelines, and then what clinicians are supposed to just kind of translate to practice and outcomes, right? So this is kind of framed as by this guy, David Chambers, who I really like in the implementation science field. This is the traditional approach to implementation. And there are some assumptions that are made for this to work. One is that the evidence is certain, that healthcare systems are static, that populations are homogeneous. And then if all of those things are true, this works pretty well. And so the emphasis is on fidelity. Do the same thing for each patient every time, right? And when we think about, I like to design decision support tools. When we think about kind of implementation strategies, they're really, using these tools to really improve fidelity is the goal. And so the role of the clinician there is to really just do what the guidelines say, right? But there's a new approach that Dr. Chambers calls embracing dynamism, which I love. And that it looks a little bit different. So if the evidence is uncertain and healthcare systems are dynamic and populations are heterogeneous, does this sound familiar? Change is central to the evolution of evidence-based practice. And so we actually want to be paying attention. We don't necessarily want to have fidelity. And the emphasis is more on adaptation. So then when you're trying to design, pathways or decision support, your goal is not necessarily for doctors to just do the same thing every time, is to actually design it such that it allows deviation, but to kind of actually listen and learn from that deviation. And so a clinician's role in this space, which I would argue matches pneumonia care quite a bit better, is to actually face those guidelines and really be critical about whether they fit for their patients and to be free to deviate if they don't. And then for, our job is actually to learn from that deviation. So I've been working with CHEST actually on kind of an infographic. They're all into infographics. And kind of just, using for bedside clinical providers, kind of what the best basic principles of pneumonia care are. Are they really that you get antibiotics X, within X number of hours? I would say that's not really the basic principle, but I would say that these are kind of key basic principles. Do you have the right diagnosis? Have you assessed for host susceptibilities? Why did the patient get pneumonia? Assessing clinical response and picking some really important time intervals. I would argue quite frequently, especially in ICU patients, of really thinking whether your patient is responding to treatment, because that simulates kind of a deliberative moment to think about whether you have the right diagnosis or if there's something else going on. Managing the patient beyond antibiotics. Honestly, the question of antibiotics and pneumonia, it's a simple solution to that simple problem. It's taken up way too much oxygen in the room, and it's actually kind of stagnated the rest of our field to developing better, other ways to, restore lung health in lung infection. And so the way I think about managing beyond antibiotics at this point is we think about, complications like sepsis, respiratory failure, airway clearance, and then we now have kind of phenotyping patients for the host response immune modulation here. And then thinking about recovery and prevention and whether those host susceptibilities that we've identified are actually something that we can address and mitigate so the patient does not just have a pneumonia again. And here's how I kind of conceptualize it. So I've been thinking about how to help clinicians individualize pneumonia guidelines. Oh, and this was supposed to be animated, but it didn't work at all. So what I've tried to do with kind of new updates is with every recommendation that we provide, really also be very transparent about the strength and evidence quality about that recommendation so that clinicians can have easy access to, well, is this a really super strong recommendation, or what is the evidence base beyond that? And then really ask clinicians whether it's generalizable to their patient population, providing in a really transparent way factors that might strengthen a recommendation and factors that might weaken a recommendation. So taking it as an example, we've got from the 2019 guidelines, we over recommended broad spectrum antibiotics for pneumonia in 2007. And so now we're backpedaling, and in 2009, after this whole HCAP entity thing, you guys all know probably that backstory. We now kind of realized that now we're overusing antibiotics that have killing activity against MRSA, Pseudomonas, and stuff. So we're now kind of backpedaling to this space where we're like, oh, don't use it all the time. And so the guideline in 2019 was only cover, for MRSA, Pseudomonas in adults with CAP if there are these risk factors present. But there's really very few risk factors, actually. And then the strength and the evidence quality, you can see that this was actually a strong recommendation, and they said it was a moderate quality of evidence. So, okay. But then there are always factors that strengthen or weaken that recommendation. And so, an example is, well, if I in my community have a really low probability of resistant organisms, if my patient has really low risks of harms from undertreatment, that would strengthen this recommendation. If I've got an increased probability of resistant organisms for that patient, that would weaken the recommendation. For example, patients with influenza or cavitary lesions that might increase my risk of community-acquired MRSA, things like that. So this is kind of the way I'm trying to kind of help clinicians frame an individualization framework without asking them to know every single randomized clinical trial that was done. And kind of from a system perspective, thinking about it, I work with the VA a lot, and we've noticed that this is a study that I did before COVID on MRSA and pseudomonal antibiotic kind of prescribing, with a widespread variation across the VA system. And so we noticed this, and this seemed like a lot of variation, but in 2018 or so, we weren't totally sure whether like how many people should get broad spectrum antibiotics, right? There's a lot of decision uncertainty around that. So what we decided to do with that observation was we decided to do a study. And so I leveraged this variation, and we worked with some causal inference statisticians to do comparative effectiveness research to ask the question, did any of these patients that received anti-MRSA therapy actually have a clinical benefit to their 30-day mortality risk? And what we found was that there was really not a single group, even patients with, MRSA PCRs, high risk of MRSA. There's not a single group that we could identify that actually had a clear benefit from this therapy. And so that kind of increased our confidence in saying, gosh, maybe we really shouldn't be using broad spectrum antibiotics for patients with pneumonia. And so then we kind of looked at the data again, and this is current data, and we can see that we kind of have the water the high watermark for broad spectrum antibiotic use in pneumonia has kind of started to roll back, right? But it's a lot harder to de-adopt something than it is to adopt something. So we were kind of peaked out at about 35% in 2016 or so. And now we're kind of 31%. Now we're down to about 23% after the pandemic. I really thought this was going to get like way dramatically better, but it's still a lot of patients are getting broad spectrum antibiotics. So what do we do with that? We're kind of a little more certain, like let's kind of nudge providers into, like giving them information about what their actual population risk is to kind of help them calibrate this a little bit and feel a little more comfortable not using these antibiotics unnecessarily. And so this is an example of just a decision support tool that we have at my VA, which really kind of gives people a little bit of information about what the population risk of resistant organisms is. And then it still provides them information to, you can order it if you want, but better yet, you can actually, build into these decision support tools, actually an override and ask them like, oh, why did you do that? And so that's actually what we did with Intermountain Health. We really, through decision support, we tried to capture reasons that physicians actually consciously deviated from hospitalization guidelines. And this is one concept mapping project that I did with text entries of when a physician overrode a recommendation from their decision support tool. The decision support tool just asked the provider, oh, well, why did you do that? And so the clinician actually could free text. And it was actually surprising, about 80% of them left a free text. There were drop-down menus, we tried to make it easy, but most of them actually wanted to say something. And so this is conscious deviation. This is the kind of deviation that we want. But we were able to kind of capture that. And then that's something that can inform your, pathway and your decision support and even your evidence base. Have I got time for analogy number 3? Time is it? Because I can skip the octopus. Okay, all right. So let's see if I can. Okay, so about halfway through the COVID pandemic, I started to think about the VA as this octopus. Okay, so give me a second. All right. So octopus are really interesting. They don't have a central nervous system, right? And they're super smart. And they actually have a pretty good memory. But most of their neurons are actually outside, like their neural kind of stuff is all in their arms, right? And they're incredibly quick and dynamic, right? Because of that, probably, the nervous system is super adaptive. And so you have these arms that are reaching out and they are responding to their environment in their context, like way faster than they could if the signal had to go all the way to a central nervous system and then back again. But they have a brain. It's like kind of this tiny thing. And they actually recognize people. They can do these crazy things. Like they can learn how to there was one aquarium in California where an octopus learned how to turn the lights out by squirting water to the fuse box to they're incredibly smart, but they're not smart in the way that we think of vertebrates, right? And so I thought about this. So the VA healthcare system is a huge system, right? It's really brilliant. It has a pretty strong central kind of central nervous system, right? We try to control a lot of things from central office. In the COVID pandemic, that model, there were times where it broke down. You could not go all the way up the chain to get approval to do certain things, to move your staffing around, to build ICU beds. You actually had to do that all in the office, right? And so this is a complex adaptive systems model. And I would argue that this is a better model for healthcare, where you're actually allowing autonomy, a lot of autonomy at the clinical field. And you're allowing your clinicians to really respond to their context and adapt their guidelines to their existing environment. But you're also learning from that. Every time they do that, they have an adaptation. If you pay attention, then you can kind of bring that into the central memory. And when you study octopus, they actually have this, they call it actually rules of improv. There you go, circling back. And they do actually, follow, you can even agent-based model like octopus, because they follow these few rules and they learn and they have memory. And so I would argue kind of we have to, for every condition, if you're, studying asthma or, geriatrics or whatever, thinking about what your core rules of improv are. And those are the rules to really follow. Because when people play jazz, they don't just not follow rules, right? It isn't just chaos. There are rules of improv, but they really have to allow lots of adaptation. Did that work? I can't eat octopus anymore because it's just like I read too much about them and they're just like amazing. All right, so these are kind of lame cases, but I know everybody likes to have cases. So here's 2 cases for you. Okay. So here's the case of Mrs. A. Let's see. She's kind of a 60, and I have to warn you, this isn't a pulmonary case. Okay. So this lady is 65. She's got like diabetes. She comes in, just kind of vague symptoms, but sort of feels nauseated. And so, the resident like worked some stuff up, and here you go. You got some diagnostics. What do you think it is? Anybody? What do you want to do? Come on, guys. All right, let's take her to the cath lab. Okay. Oh, what did you see? I think you remember what that is? I think there's an obstruction there. Okay. So let's revascularize, right? Ah, phew. Okay. Oh, look at that. She's feeling so much better. Yes. Satisfying, right? Yes. Okay. Good job. That was a stent, right? This is Mozart. You have to have, your time is everything, right? You want to have tight adherence to protocols. This is where you have the kind of mechanical systems. You have lots of coordination. You get that patient what they need. There is attention to the patient's individual kind of needs, but it's quite a bit more like all about tight adherence to protocols, right? All right, let's try Mr. G though. And this is a real patient that I had at the VA, one of many doctors who took care of this guy. So Mr. G, he came in, he was like a 55-year-old guy with a history of asthma. And he just came in, he kind of like weird to me, he was just like a little bit confused. He was having dyspnea. And so they checked his SAT, and it was like January or so. His SAT was just like, and this is Salt Lake City, this wouldn't be a terribly abnormal SAT, it was just a little on the low side. And his influenza B came back positive. And here's his X-ray. So what do you guys want to do with this guy? Please say Tam. What do you say? What do you want to do? Want to send him home? Want to admit him? This is tricky, right? There's not really a right answer, but what do you want to do? How old is he? 55. X-ray looks great. Just kind of off, there's something off about him.
I just bought it.
Okay, more imaging, okay, all right. So actually they didn't do more imaging, but they did decide to admit him because he just seemed a little off, and then they couldn't put their finger on it. If you ran a protocol on this guy, maybe it would have bought in with, oxygen needs, but he did have asthma, so that'd be, okay, all right, reasonable, totally reasonable admit. So then this is day 2. He develops a confusion, more work of breathing, and then he got intubated, actually. All right. And then on day, I think this is day like 4, okay. Then he develops shock, acute kidney injury, and he gets rushed, or no, he's already in never mind. He has positive blood cultures. There you go. Yeah, so this was a real case. It was quite interesting, and we started to develop a term for this entity. Have you guys ever seen this? So really interesting. So we have this kind of interesting changing model of pneumonia. Like a lot of it is probably viral, right? But also there is this layup that viruses can kind of provide for bacterial invasion in some patients, right? So this was kind of the thing that you were worried about. You get scared. But we actually did, I think, a great job with this case because the ER doctor was free to make a clear decision that, was based on their kind of gut, their intuition. And we actually want that in our clinicians. And we were actually able to, have him in the right place at the right time. If this patient had gone home, he probably would have died. Kind of that nimble, and this I would argue is jazz. So precision here, great care is actually not about just following the protocol. This is actually about adapting, about paying attention, and really thinking about clinical response and being nimble. All right, so here's my slide. So I kind of am like geeking out even way too much about music, but there is this really fun kind of rules of improv. These more rules of improv for jazz. If you're interested about it, there's that website. But I would say that guidelines should be kind of thought of as these rules of improv, but they need individualization. And so they kind of represent, the musicians call this the musical structure. It's our collective knowledge in our historical context, and you apply that every time to your individual patients. And we do expect clinicians to deviate from this quite a bit, but you also have to know the rules in order to break them. That's a jazz quote, and it really, I think, applies to clinicians too. If you just do lots of stuff, and it's like the Wild West, as I, being from the West, can say, you don't really have meaningful variation, right? We want variation that means something, which means everyone has to actually know the rules, before they break them. And in pneumonia, because of our evidence uncertainty, diagnostics uncertainty, heterogeneity, give us another 30 years, but in the meantime, we'll probably be playing jazz for quite a while. And there is all of that. And so precision here, doesn't mean tight adherence, it means attention and adaptation and responsiveness. And to support that, systems leaders should not actually, just count up all the patients who had guideline concordance. They should focus on supporting those key principles, and then provide transparency and flexibility. And then the holy grail is, when using kind of a learning health systems approach model, as learning from the deviation. When clinicians actually consciously don't think that the guidelines fit for their patients, we should be listening to that. And I'm going to save the research stuff for tomorrow. Okay, one last neuroimaging thing. Okay, so why can I not learn jazz? All right, so this is a really cool study from the Max Planck Institute that I liked, which just compared kind of the, like they put brain electrodes on classical pianists and jazz pianists, and then they forced them to like play a harmonically unexpected chord, so like boom, bang, and classical pianists had this different brain response. They showed a tendency to build these narrower structural plans, and then jazz pianists had greater readiness and flexibility to revise their structure plans in case of harmonically unexpected chords. So since we're in a teaching institution, our kind of final question is, how do we actually encourage this in our clinical education? How do you teach, when to play jazz and when to play Mozart? Because we actually do all have to have these two different ways of thinking. And when do we kind of help clinicians toggle between those things and switch? So, oh, wait, back to analogy too. Okay, all right. Here's one last thing. All right, so Everest, a lot of people die, and the thing about it's another really gross thing is they just leave the bodies, right? So here are all the bodies on Everest, and people are really focused on that, really trying to avoid death, of course. And just like in medicine, you have a lot of plans, but as they say, like plans are nothing, planning is everything, and you have to deviate from those plans. And there's a pretty solid, 1% chance that you die if you try to summit Everest. But I would argue pneumonia actually in hospitalized patients has a 10% mortality. And so clinicians are really on the sharp end. So we can make guidelines and pathways and everything, but we really have to respect that patients and their physicians are on the sharp end of these guidelines. And we always have to preserve the ability for them to deviate so that they can treat the patient, not the disease. Yeah. So that is my talk, but thank you.
Thank you so much for that amazing talk. I loved your analogy.
They run a little flat. So.
No, it totally worked. But I will open this wonderful conversation for further discussion, and I'll take some questions.
Want to go first, Clara? Please.
Thanks, Barb. That was a great talk.
Great to
Really,
see you.
really enjoyed it. Good to see you too. I'm thinking more about your slide about the initial starting diagnosis in the ED and then the crossover over the course of the hospitalization. That happens all the time. I think we could pick any diagnosis, COPD, certainly many others, where that is the case. And I think part of that is just the way medicine is. We start out with symptoms and a physical exam, and then we have to come up with a differential diagnosis and think what's most likely initially, and then the information evolves. One huge problem is that we're left at the end with diagnostic codes that get entered, which are often wrong. And that's a huge problem, because then people get labeled as having certain conditions or certain risks for certain conditions that then get carried forward. How do we do a better job of tackling that? That's
Yeah,
a terrible
yeah.
question, I'm sorry,
Yeah,
but.
no, it's great. Okay, well, let's see. If I were a president, it was actually, this is really interesting because for diagnostic quality, you know, we both kind of play in that space, you with COPD and me with pneumonia. But I was actually part of a kind of a think tank, NQF kind of, they brought a bunch of people together to talk about how to improve diagnosis in healthcare. You know, politicians and policymakers actually have power to change rules. And so I was getting into this space of developing quality measures, which then potentially be used by like CMS and stuff to improve diagnosis. And the only thing, the thing I was really worried about is, man, don't target all this to the emergency department. That is not appropriate. Emergency department physicians tell us again and again that, I don't know, they're quite comfortable with uncertainty. There isn't a space in the EHR that's really that great for them to store that information. So we just have to preserve that in our narrative. But yeah, but by the end of the hospitalization, gosh darn it, you probably should get the diagnosis right, or at least, you know, be, at least for most patients. So I developed a measure that, you know, just identified chest imaging, you know, like evidence of pneumonia, and contrasting that to try to improve the diagnosis of pneumonia. But we were at this think tank, and you know, and that would be one thing, you know, really hold patients, you know, providers to those labels, you know, like, well, okay, you say that the patient had COPD, but where's the evidence? It's in the health record. You know, we can actually develop tools to validate that, and that would actually improve our research, because it'll improve our health services research. And then I really think it improves care, because the patients come away with those diagnoses and that's what they think that they have. And then they tell their primary care physician. And so that is super important, and especially because our care is fragmented, right? So I think just improving those through incentives, that could work. The other thing about this think tank, it was so funny because I was just like, man, you know, if I could do anything, I would just make the diagnosis codes like possible, uncertain, you know, like qualify them. They're like, we could do that. And I was like, what? You can do that? And they're like, well, yeah, I mean, ICD, you know, somebody created those ICDs. Like you could revise the diagnosis, you know, you could really think broadly. We should be mapping our labels. We should be making codes that actually map our thinking better. And so I was just like, you know, like, because of the health services researcher, I'm just like, I just take the data and I, you know, like, I know there are issues, but I don't try to, but you can actually really start having these conversations about how do we make the data actually reflect, you know, how do we make the EHR have space for uncertainty and have space for the actual reality that they're supposed to represent. Yeah.
I think we also need accountability on the other side too. We need a way to feed back after all is said and done, to be sure that what's coded is reflective of what actually happened. And that's still often not the case. So we have to work on that.
Yeah. Validation and a very data scrutiny is super. Yeah. I love those comments. We're on the same page for sure.
Thank you so much for that. Awesome talk. In the spirit of improvisation, I think we actually in the ICU do a fair amount of that. And I found myself when you were, I think, sharing the 2019 guidelines slides about really covering MRSA, Pseudomonas, and very much more narrow circumstances. And I think you even showed your own data that there was some harm if we did that. I find myself coming back to data, I think, that Merrim Caller published from Washington University, maybe 15 years ago. And I think this impacts my thinking a lot in the ICU, that broad coverage up front, particularly when patients are coming in, hypoxemic respiratory failure, septic shock, helps with mortality. And I guess I'm wondering, are some of those pneumonia 2019 guidelines relevant to patients coming into the ICU?
Oh, that's a great question. And I think it's Collis, right? Yeah, that group, and he's still doing amazing stuff and has some mentees that I work with now that are really great. And it's really interesting because we have this, there was sort of an emergence as a result of some of that work and others is sort of the, broad first, kind of upfront. And I really think that needs to be still allowed, right? Upfront, broad antibiotics for a patient that you're really uncertain about. One thing though, I think that anytime we are thinking about, and especially for sepsis, so the thing about this is a problem with guideline, condition-based guideline-based care is you are not just applying the CAP guidelines, you're also applying the sepsis guidelines. And what is an ER doctor to do when the CAP guidelines say, don't you dare give those broad spectrum antibiotics, and the sepsis says, give them, and within 4 hours, please, and so it's like, okay, all right, so they're being tossed around, but actually that's kind of good, I think, because you do have this sort of stakeholders and, different kind of, you have to balance that as a clinician. But I do think making sure that we know where that concern is coming from and whether broadening the antibiotics is actually, like a lot of times it's a marker for illness severity. And, I've had people die of strep pneumonia. I remember as a fellow with my mentor who was a pneumonia expert, watching a 65-year-old woman die of strep pneumo and wanting so badly to give that person vancomycin. And he said, telling me, I know you're worried about this patient, but she does not have an additional infection. This is not why she's dying. And so sometimes I think that a good motivation for, if you're thinking of pulling the trigger of, broad spectrum antibiotics in pneumonia, we should be always able to do that for patients we're concerned about, but it should stimulate more diagnosis and more thinking about, wait, why am I so concerned about this patient? Have I missed something else? And then one thing that I actually think that the 2019 guidelines tried to say, and I think did pretty well, is if you're sufficiently concerned about a broad, a resistant organism to treat for it, you really should be sufficiently concerned to be looking for it aggressively with diagnostic tests. And that means PCR, cultures, and do your due diligence. Don't just give people antibiotics and try to get a better diagnosis too. And we talked a little bit today about, thresholds for treatment versus thresholds for testing. That's going to change a lot over the next several years, because we have a lot more pressure, and I think it's probably appropriate to be more judicious about antibiotics, right? To do less. But that doesn't actually, and oftentimes that means that we should actually diagnose more, So if I'm feeling like maybe I will withhold a certain antibiotic because, it's good for stewardship or public health or something, but I can't be as sloppy with antibiotics as I used to be. But that actually might mean that I double down on my diagnostics and I actually, my threshold gets lower. So it's all kind of shifty and improv-y, but I hope that was an okay response.
So I'm constantly thinking as you go through between Mozart and jazz, and how do you put the jazz into the guidelines that you're assembling as its leader? Because you're proselytizing, you're really telling us we got to be thinking in this direction. How do you make that happen? Is because you believe in this.
Yeah.
But you're running the guidelines.
Yeah. Okay. Without violating my confidentiality contract or something. Basically, on my watch, basically as much of the guidelines are conditional, conditional, unless you really have great clinical trials that drive a strong recommendation. And actually, the IOM is suggesting that too. is that we should, I mean, just because clinicians feel strongly about something, if we don't actually have sufficient evidence to support that, that's kind of reserving though. What really matters, what is the strong recommendation? And I would probably say is like, get a chest image, make sure that you have the right diagnosis. Like that's probably a strong one. You know, look for sepsis and respiratory failure, do your due diligence for lung protective ventilation. These are the strong things that we really do to make a difference. Giving, you know, antibiotic X versus Y, I don't know, you know, some of those are strong, but they, you know, we should really be thinking about how strong they are for an individual patient.
So while I was listening to your amazing talk, I realized, where had I heard this before? And I had listened to your podcast on Amazon Call a couple of weeks ago, and I shared it with the residents. So just a public service announcement. If you want more of this, it's really worth everybody's time.
Thank you.
My question for you is, I think it was probably at least 20 years ago, I was at either an ATS or SCCM meeting, and there was some faculty from your institution. I don't know if it was Terry Clemmer or Alan Morris, they were talking about how they had been among the pioneers on protocols.
Yes.
And one of the points one of them made, or somebody made, was that there was some sort of emergent property to protocol, that even if you were doing something that was almost suboptimal, that was better than everybody trying to do their best.
Yeah.
And at the time I was MICU director, and I realized that this was like the tension, right? Like everybody thinks that they're going to do the best, but from a 20,000 foot view, it can sometimes appear chaotic. Like what's actually driving decision making.
Right.
So I'm wondering how you think about that now, a couple of decades later. Like, is there an emergent property? Should we be telling people that, you know, your bright idea may not be so bright, or do we want to encourage them to be more free about education?
Well, that's wonderful. And yeah, very close to my heart. So like in terms of my own personal trajectory, I started out kind of my research at Intermountain, and I started out thinking variation was bad. And I do think still there's a lot of variation that's bad. And Brett James was like the CMO of Intermountain for a long time, and he really spearheaded a wonderful movement in you know, I think integrated healthcare, but Intermountain really did a great job, you know, creating learning health systems, driving quality improvement through sort of applying some of the system engineering stuff like Denning and, you know, these. And his quote was, and this always sat, it seems a little paradoxical, but his quote is like, well, it may not be, it's not as important for doctors to do the right thing every time as long as they do the same thing. And I thought about that a lot. And what I was doing as a resident is, we have a pretty strong protocol kind of culture in Intermountain. And some of it really is amazing, especially in ICU. For example, like electrolyte management. Do not like rely on, you know, residents and interns to human manage like potassium, right? Our ARDS protocols at Intermountain are basically RT driven, and it's kind of like big to me. I really think that like automation there's an extension of cognition that as long as that automation is kind of designed really well and is, you know, explicitly, you know, kind of like adequately explicit, as they say, it really kind of extends, it is the arms of the octopus, right? You're not just having everything in the clinician's head. And so you're offloading cognitively to, you know, RT and to protocols and stuff. But what didn't sit with me well with, so for Intermountain, I was really trying to use kind of the traditional approach to evidence-based medicine, which was apply the guidelines, make sure everybody gets the same care across the whole system. Darn it, because that's equity, right? That's, you know, justice. But then I actually tried to apply that same protocol to a clinic that was extremely special and difficult population, which was had predominantly homeless people. And I saw where it just totally fell apart. And the problem with that design is if it's centrally located, the flagship hospital, the Mass General, the Yale, University of Utah, the Ivory Tower, once you actually try to scale, it just completely breaks. And that's one thing that I think there is some wisdom in that there is this emergence of the protocol. But I don't really think that the designers of the protocol are inclusive enough and representative enough to actually account for all of the contextual nuances that clinicians in the field really are dealing with. And until they do that, and there may be a time when we actually are learning from, you know, the field that's really represented, until they actually include those perspectives, the protocol is not going to have the magic that is promised by those people. But
All right. One last quick question, or do you want to save it for after? All right, so we're at time. Thank you so much.
thank you.